Yo, 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 yo. Welcome back to another great episode of the Best Practices Show podcast. My name is Kirk Behrendt. I have one goal here, to make you better. And when you get better, your practice gets better. And then what happens is your life gets better. So you can expect that from us every time you show up to this podcast. And today is no exception. I'm going to introduce you to an amazing young influencer in dentistry, one of our favorite. He's such a great thinker, and you are going to love this guy. And today he's going to cover, his name is Dr. Drew McDonald, and he's going to cover the necessity of CBCT and MRI imaging in today's orthodontic diagnosis and treatment planning. It is fantastic. So hope you enjoy it. We'll see you soon. Hey guys, welcome back to another episode of the Best Practices Show, where we take a look at the best business practices from the best practices and the best minds all over in dentistry. And today is no exception. I have got an incredible rock star in the world of dentistry, and I got to know this guy 2 years ago, Drew McDonald. And today we're going to be talking about the necessity of CBCT and MRI imaging in today's orthodontic diagnosis and treatment planning. It truly is one of the hottest topics ever, with what I consider one of the up-and-coming rock stars in this great conversation and profession. And Drew, great to have you on, brother. Thanks for being on, man.
Yeah, thanks for having me back. I know, just good to see you again this way. I know I hope to see you in person again, but yeah. I know you and I were talking earlier just that this is kind of, today is the 16th of March, is kind of the anniversary of what even started all of what you've done for dentistry here, Kirk. And, I know that was a bad day for us as dentists, and, we all ended up kind of having to shut it down for a little bit, but I think you pretty much rescued a lot of people's psyches and, mental health there for a little while and ongoing, just with what you put together. I know just the people that I've met since and got to listen to lecture, and obviously getting to hang out with you a couple times since, none of that would have happened if some of the bad things didn't happen first. So you made something that was terrible for dentistry and a lot of our lives something that was a whole lot easier. So thank you so much, Kurt.
Hey, it's my pleasure. And in all sincerity, like you and I, as we were chatting, you were like, hey, this is like 2 years ago. I was like, oh, I must have buried that pretty heavy in my memory, or either the trauma of it, because the truth of it is, Drew, I needed to talk to people more than anything. I went to a really, really bad place with my own mental health, and I had a panic attack. Like, I had a full out panic attack, and you guys, I needed all of you, and I didn't know you. And actually Jim Otten had said, he's like, hey Kirk, we got to get this kid on Drew. And I'm like, who is he? He's fantastic. And so I got to know you. I didn't realize you didn't know Becca Backow, and you guys are now working together, Tracy Wynn. And it was like all these rock stars started emerging, and it was really cool because this profession is so noble. That's what Bill Robbins kept reminding me. He's like, no, this is a great profession. And 40 years of practicing, it's good to hang around with somebody like that, because he's very calming. If anything, it was like fireside chats with Bill Robbins every day. It was easier to listen to Bill than it was to watch the news. So there was a lot of good that came out of it. So it was good. But
yeah, absolutely. No, it's a lot of learning too. I mean, shit, I learned so much from everybody that you had on the program. And like I said, I appreciate everything you put together. That's a lot of work. And anyway, it's great to be back and hanging out.
Yeah, it's so great. And I'm going to have you back again and again and again. And I just got you to voluntold yourself for an orthodontic summit here at McDonald. So it's funny how that works. But we'll get into that later. But Drew, today, one of the many topics we're going to cover is the imaging aspect of things. And so you sent over that note, like, I think we should talk about the necessity of CBCT and MRI imaging in today's orthodontic diagnosis and treatment plan. Now, I always like to start, number one, let's do two things, if it's okay. I want people to know who you are. So we have a lot of dental students listening. I want them to know who Drew McDonald is. And then I also, after that, let's go into the why before the how. So who are you first?
Yeah, so my name's Drew McDonald. I'm an orthodontist, private practice in Albuquerque, New Mexico. I went to Creighton Dental School for my dental education DDS, and then I went on after that to UMKC for my orthodontic education. So, and a lot of what I do in my practice is very focused on TMJ and airway based, kind of beyond just the teeth orthodontic kind of things that we're doing. And really, what got me into that was not just the dental school things I learned. Quite honestly, dental school education was just the tip of kind of some curiosities for me.
Yeah.
And at the end of all that, that's where I started, kind of pursuing other CEs, especially the airway side. And that's where kind of Becca and a few other people and Jeff Rouse all really started making a lot of sense to me as an orthodontist, because I was seeing those airway patients every day in my chair. And I just didn't know to look for it before I knew those guys. And then back to, onto the bigger things that I look a lot at, and what I've kind of talked a lot on this program about is the jaw joint aspect. And I know a lot of people think, that jaw joint patients are, a certain breed of patients that maybe we don't want to be seeing. But what I've found, and what Dr. Mark Piper and Dr. Jim McKee and, some of those guys that have just been huge influences on me on the joint side, what their truth that they really showed me was just how much involved the joints are in growth. And in young kids that show up in my orthodontic chair with growth issues, that we can't just treat it like it's a genetic problem. We got to look at it as this is coming from somewhere. And the joints, the airway, they are such a part of why these patients are orthodontic patients.
Yeah.
And so, what we're going to talk about today, obviously, is how do you even recognize those patients? You got to do some imaging, you got to do some homework to be able to see what's under the surface.
Yeah.
And then you know how to treat them. And,
Yeah.
and it helps at such a bigger level.
Yeah. Can I ask you a question? You didn't know I was going to ask you this, and I didn't even know this, but I did some homework on you. So Jim Houghton's like, you should ask Drew, like he was a pretty amazing baseball player. So you've never talked to him. You're such a humble guy. So you were pretty good at baseball, like, weren't you?
I was okay. I keep forgetting about that season of life for me.
You were okay. That's not true. You were really good at baseball. Yeah. Tell us the story.
Well, yeah, so grew up in Tucson, Arizona. I played baseball my entire life. I was a catcher. I was drafted out of high school by the Seattle Mariners. Wow. At that point, I had kind of had an arm injury towards the end of my high school senior year, and I got drafted a little later than I wanted to, and I was kind of pissed about it. Mm-hmm. So I had a scholarship to the University of Arizona at that moment for baseball, and they had been just to the College World Series the year before. And I kind of was pissed enough to where I was like, screw it, I'm not signing this contract. I'm going to go back to school and get paid more whenever I get done with school, kind of thing. Well, the best laid plans ended up with me getting hurt again, and arm was, I ended up, kind of finishing up baseball after college. I didn't go on and play anymore. But it's the best thing that ever happened, because I never would have gone to dental school, met my wife. All the good things that have happened came because baseball didn't work out.
Yeah, so that's very cool. It all worked out. I did not know that about you. I did not know. How cool is that?
Yeah. It just, shoot, it's 15 years ago at this point. I'm sitting here going, damn, that was a lifetime. But my knees still tell me about it. I can't walk up and down my stairs without waking up my kids at night.
Yeah.
Anyway,
that's so cool. That is so cool. So now let's go into the why behind this. And I have so many questions on this whole thing. And it's funny you brought up Jim McKee, because he's fun to have on here. Like Jim McKee, now we're going to pick on, and I'm going to make Jim listen to this. So he's a mutual friend. So hold on tight if you guys are listening. So I joke with Jim. Jim was one of the first people I met, and Jim deals with some of the most difficult cases in all of Chicago. He's crazy busy, and he helped me early in my career when I was speaking. He picked me up in the car, and I was so nervous, and he's like, kid, just breathe in, you'll be fine. And so I joke with him that, like, I don't even know if he's a dentist, because his website is terrible. He does, like, you can't find him anywhere, and he's like crazy busy. And he also gets those patients that we joke about and go, no, those are the crazy patients. Jim's like, no way. Like, everyone says that these people have complex problems. You just need to understand them. And he's built an entire career of understanding what we don't know. And that's part of what we're going down this path in this whole airway conversation, right, Drew? Even in ortho, right?
Oh yeah, no, for sure. It's the what didn't we know and what drives us crazy. practitioner wise, I mean, that's what drove me into doing all of what we're going to talk about today, which is, getting to the heart of the real problem, not just chasing it at the teeth level. So, back to Jim though, he kind of similar moment with me. We were at the then Piper McKee Study Club, and Mark put that together. Jim was, obviously involved as well. And obviously, I was just the new guy. I was the one orthodontist in the room who was sort of curious because I kept running into these orthognathic surgery patients that I had done their treatment, and then you see them start to relapse. And I'm going, why is that happening? The best answer I've got is this is idiopathic. What is that? That means we don't know. And so, Jim the first day I was there, I had some very typical orthodontic comments that I could tell maybe made some people be like, who invited this guy? Like, what the hell? And so anyway, Jim, that night, he kind of took me aside and was kind of like, hey, I can see you're interested in this stuff. Like, can we, kind of be a little bit more? And from that moment, Jim became a very big mentor for me on a lot of what's happened next, which is, he's really kind of guided me through, thought processes of what I'm looking at. He's really helped me develop a lot of lecture content. He's just a great mentor. I mean, he's just a guy regardless.
Yeah, and that's what Jim said to you, but he called me right after that, and he told me what he really said to you. He said, young Skywalker, the Force is strong with you, is what he really said. And so we all knew that when we got a chance. And that's how we got together when we were putting together this conference. Is Otten, Jim, who's just a dear friend of mine, he's like, no, I mean, once you meet Drew, you'll see. He's like truly, this kid's got a lot of potential as a great leader, great thinker. And then we had you on again and again and again. And as you guys will see today, you're changing the world. I joke, but this is not a joke. I tell you and Becca every time I talk to you, you guys are changing the world. You really are. It goes way beyond the joint and like the palate and all that kind of stuff. I mean, people, this is a big conversation. I feel like we're only on the tip of it. We're only beginning to understand what we don't know. And now, as we dive deeper, I think we can only learn more. And today we're going to be talking about the imaging. And so let's go back to this. Can I ask you, Drew, let's talk about the why. When you talk about imaging, let's start with the big why behind the CBCT and our MRI imaging and why that's so important.
Yeah, so kind of back to where I was going there which is that, a lot of times we run into problems as orthodontists with a patient with, a certain type of, we're trying to accomplish this and we're running into walls. We're just running into walls. And unfortunately, a lot of the handicap of some of the orthodontic education that we got, and I went to a very progressive residency, I will say, UMKC was very cutting edge on the airway side of things. And but at the end of the day, like I said, the biggest thing of the why for me on what we're talking about with imaging is that it's the truth. You can't fake that. It's right there in front of you in the cold black mirror that you're looking at on that X-ray or that MRI. And ultimately, it tells your patients the truth. But for me, whenever I started going down the road of, okay, let's see what's under the surface. Let's see why this patient isn't responding the way that I anticipated. That really shed a lot of light on, what are the true problems here? And, whenever we see these kids that we did expansion on in phase 1, and all of a sudden they come back for phase 2 and they look like they were never expanded because they've relapsed so much. And then we start looking, like Becca will talk about, is, well, there's an airway issue. There's a tongue issue under the surface this whole time. And I joke, and I like Game of Thrones analogies, but what's dead never died there. Essentially, the same damn thing that got to them in your ortho chair in the first place is what reared back up, and it's causing them to relapse.
Yeah. And
the other unpleasant conversations that you get to have with patients when that happens is, well, I thought this was going to stay. Why didn't it? And it starts to look like you as the doctor didn't do your job.
Yeah.
Well, no, if you did your job at the front end and diagnosed and said, hey, we need to take care of not just the teeth, but these issues to keep this stable, then you really did your job and you're in the clear as a doctor. So,
yeah.
So anyway.
And can I ask you about this too? Because I'm going to totally screw this up. And, Jeff Rouse has said this on the show. And Jeff, I'm sorry if I butcher this too. He's like, we got to be careful about what we know for sure. And he shared on our show, even my treatment planning process has changed. I never make big promises. I tell patients, we're going to do this phase. We're going to get as close as we can. And then we're going to evaluate that clearing where we're at. And then we go again. And do you see that? People are going to be living longer. Palates change. I mean, I could show you my nostrils, and that's not what this show is about, but I'm my third time through ortho, and it's changing my face. And I'm grateful because I can breathe more now because I know more. It's almost dangerous that you know more because then you see more. But your perspective on how we treat, would you agree with that? We can't make too many big promises in treatment as we talk to patients.
Yeah, exactly. And I think that that's a lot of what the imaging and seeing it beforehand tells you, what are the limitations here?
Right.
Are we going to treat this patient to ideal? Is it possible to treat them to ideal? Or ultimately, are we going to look at some sort of compromise because we don't want to push something beyond where it should go? And again, I totally agree with what Jeff's saying. Just, we only know what we know now. And it's going to evolve. And right now in dentistry, the biggest evolving part of this profession is on the imaging side. I mean, I think we're in a huge revolution of how we're going to do dentistry, where everything's going to be in 3D. And people are going to routinely do MRIs, not just as, TMJ specialists. And in my world, I think I'm one of the only only a few orthodontists that do it, but it's going to be widespread.
Yeah.
And honestly, it gives so much value to the patient. We treat them to the highest standard of care possible instead of limiting what we can do.
Yeah.
But ultimately, again, it says, what are the limitations? Where should we go? Where shouldn't we go? And ultimately, how far can we take this before we need to reassess?
Yeah. And you're in a unique position. So technology has changed so much just in the last couple of years. So take us into the specifics of what you see in imaging. Now, let's also speak to this. There are some dentists that are listening to this that say, Drew, I get it, but are you telling me to go just purchase a CBCT? I don't know if I have the money for that. So help us all in that space. So what are we looking at as far as images? And then where do I start if I want to go in the direction you're talking about?
Yeah, so I think, where I started and what kind of led me down this path was I started with the typical ortho images, which is a pano and a lateral ceph. And, a lot of things that I was starting to notice, I was very fortunate to buy an office with a very old CBCT, but it was a very small field, just if you ever need it for an impacted canine type of situation, I would use it like that back when I first started. But what I started to notice was on those rare cases that I would take the CBCT and kind of see the impacted canine, but also see the nose at the same time, I was going, things are running together here a little bit. We're seeing nasal breathing issues. We're seeing narrow palates together. We're seeing this whole kind of continuum that there's a lot of research supporting in 3D. And again, and then you start showing patients that and they go, oh yeah, I can't breathe through my nose.
Yeah.
I've never done very well. And then we go, okay, well, this is part of your problem. So back to kind of, as I started to tiptoe into the imaging world, it was, verifying basically, I started kind of looking at my 2D x-rays and then looking at the 3D and saying, well, I can kind of see this on the 2D. Like on a lateral ceph, you can see adenoids clear as day. You can see tonsils clear as day. Yeah. So you don't necessarily have to be totally in the 3D world at this moment to be able to start looking for the things that we should be looking for. I mean, on a pano, you can see turbinates clear as day on a lot of patients and see noses really well. And also the biggest thing, you can see joints. So just in our everyday, what you take as a general dentist, what you take as an orthodontist is, those images are still very valuable if you know where to look besides just the pearly white things in this little area right here in terms of the teeth. So that was kind of my initial deep dive or diving into it. And then I started saying, okay, maybe I should be doing this on a few more patients because I'm starting to see maybe this is part of their problem. But I was recognizing, surface issues like narrow palates and things that then I go, well, maybe I should see if there's something causing this under the surface. And then at that point you show the patient and they go, yeah, let's follow up on that ENT referral. I never thought as a dentist I'd be writing as many ENT referrals and chiropractic referrals and TMJ stuff that's never thought of as part of your world, but it certainly is.
Yeah.
And it comes up all the time. So
yeah, can you go back to that too? Because you hear this all the time. You're privy to a lot of excellent education. And that's a really important thing what you said. So just go back to it. So let's say I'm a young dentist. Like, Drew, easy to say for you. Like, it is really hard in my town to build a community of like-minded. I wish I had like even a chiropractor that would understand that, or, you know, can you speak to that? Like, what would you say to somebody when because you do get those roadblocks. People say that to you. Like, what do you say?
yeah. No, absolutely. And I will say even in Albuquerque's not a huge city. We're about 700,000 people, and there's limited providers here. Sometimes you have to go outside of your area. But the first thing you should do is be talking to the people in your area and saying, hey, I'm seeing this, and ultimately I'd like to start working together for patients, but we need to make sure I want to make sure that you kind of know why I'm sending that patient. And that's back to one of the most valuable pieces of having imaging behind it is I could go to the ENTs and say, hey, here's these pictures of this patient's nose. Can you please, this is helpful for you to diagnose and make a plan. And I'm going to send these on every patient that I send you to. Is this helpful? And what do you see?
Yeah.
And I talked with one ENT in particular here initially, and they're like, well, I've never, routinely had those in front of me on these patients, but now I see it. And so then the imaging side really did start to open up other people's eyes as to, okay, well, that's not just, wishy-washy. That's hard and fast right in front of you with that image. And so what do we do now? Instead of guessing or saying, let's watch it, like, hey, we can see the enemy, let's go for it.
Yeah.
So it's, so anyway, that's, you got to work a little bit on certain people, but it's worth the effort to do.
All right. So let's go into the specifics of each one of those. So first, let's do CBCT. What are your favorite things that you look at or preferences? And then we'll go to MRI. So like when you're looking at it, what are you looking at? What are your favorite things to see?
Yeah, so on the ortho side, I especially feel like CBCT is certainly useful for us on so many levels. My workflow is very much that I'm looking at the jaw joints first, because I want to make sure that foundation that I'm building the house on out here at the teeth and jaw level is going to be stable. And that's one of the biggest things that Mark Piper, Jim McKee, and everyone talk about is, you can win the teeth war out here or win the teeth battle out here, but lose the rest of the war significantly. And if those joints are not stable, or if there's instability there, it's a good idea to know about that before you jump into treatment and start trying to help people grow or start trying to change occlusion on somebody without understanding what's under the surface there. Back to the joints on the CBCT. The CBCT shows you, not only is there active breakdown or some sort of problem with the degenerative issue there, but it also is a very good clue as to this, how's this patient growing? If they've got short little condyles or ramuses that you can really see on a 3D x-ray there, or essentially if you also are able to measure and kind of see the volume of those condyles, which you can on a CBCT, and that they're not growing right or correctly, it starts to point towards, hey, maybe there's not just a hard tissue issue here on the CBCT, but also we need to look at the MRI under the surface and see what's going on with that soft tissue.
Yeah. And
so again, the CBCT allows you to really see what's going on there with those patients rather than just guessing and saying, oh, it's just genetic.
Yeah.
They're class 2 because it's genetic.
Right.
So I know that's kind of the first line that I'm looking at for any patient is their joints.
Yeah. And can I ask you about, so go back to, so you have another part of the CBCT that you're looking at? So
I got several.
Okay. Well, because I wish I had 2 hours with you because I have so many questions.
Oh, no.
Because you get to look at these. What do most people get wrong when they're looking at a CBCT? Like you get to see that part. What do most dentists get wrong when they're looking at CBCT imaging?
So I think back to the joints, my biggest wish for everybody, because I have a lot of patients that come to me with the CBCT, and essentially the patient's just bitten together in their centric occlusion or their maximum intercuspation instead of a fully seated joint position. And so the difference there is that if you have somebody bite together in their normal bite, that can disguise a joint issue very well because their teeth fit together and it might make their jaw move differently to get there, but it basically doesn't tell the truth of what's really happening in that joint. Right. If you seat that jaw joint for your CBCT, that's going to tell you the truth. I mean, you're going to see if there's a loss of space in that joint. You're going to see, is that joint sitting out to the medial or lateral versus, nicely centered? And those are all clues again as to what's happening. So again, back to your question, I think the biggest thing we could all do better is take CBCTs in the right position. Yeah. And that's much more enlightening as to our patient's true condition.
Yeah. Anything else you'd like to see in CBCT? Some of your favorite observations before we move to MRI?
No, I joke with Becca and all the airway people. I'm like, I was way more airway before I became the joint guy. So you guys can do it too. No, so that was my biggest thing. Like I said, coming out of residency, I had some very progressive instructors that were very kind of looking at the airway differently, talking about it. I did a lot of expansion in my residency. And obviously there's decades of research that says why expansion is good for nasal breathing. But ultimately, what I started to see, as I do the rest of my diagnosis, I'm looking at noses really hard. I'm looking at pharyngeal airways very significantly, because I feel in ortho, we have the biggest opportunity to make a change in that part of someone's life. The expansion we do here, it makes for a better nasal base. You hit on that yourself. I do a lot of MSC skeletal expanders in my office. And that's what I hear to a T is like, I didn't realize how much I couldn't breathe through my nose before I did this. But when you look at the nose, when you're measuring it on the CBCT, you can say like, hey, this is where we should be. This is where we're at. And you show a patient that like, hey, here's normal. Here's you. They go, okay, how do we change that? And ultimately people start saying yes to a lot more treatment things that are bigger. And, for dentists, it's nice because then you can charge more, of course. But at the end of the day, it's, it really does open your eyes on the airway front, especially as to the health benefits that we can have for these patients. Yeah. And that we can really create a better systemic situation for them, not just a teeth situation out here. So.
Yeah. And as an orthodontic patient, like you just brought to light, like you don't really realize how your nasal breathing goes away. It's the boiled frog syndrome. It's like slowly going away to the point where you don't even notice it. And then you're like, wow, I can't even breathe. And you compensate the other way. And you're like, wait, I should be breathing out of my nose. And then when you get back to nasal breathing, you're like, holy moly. And you'll appreciate this. One time I'm at a Seattle Study Club meeting. This is years ago. Rouse gives me a piece of tape. He's like, put this over your lips. I'm like, I'm already sleeping with a CPAP. He's like, I promise you. I'm like, dude, I could die. Like you. And I showed Sarah, and Sarah's like, I don't know if you should put that on your lips. And since that day, I've never slept without some type of tape on my lips, and I get better sleep. Like it's amazing how much better that works, right?
Yeah, absolutely. I use the Somnifix strips because they fit around my beard, but I noticed the difference too. I mean, it was about 2 years ago that I really started focusing on this because I had to have jaw surgery. I was so class 3, narrow, just a classic mouth breather, tongue tie patient. And essentially, from then and from up until I was in my 30s and had jaw surgical correction and a nasal septoplasty, I was like, wow, I can actually breathe through my nose. This is great. I'm a little stuffy today. Sorry, there's allergies out, but ultimately it's like I lived my whole life like this. I couldn't smell coffee. I couldn't do this, and the other. But ultimately, I didn't know about that. I didn't know I needed a septoplasty and all things done until I saw it on the CBCT, and I was like, damn, no wonder I can't breathe. Yeah. So, awesome. With all of that, but anyway, I do the lip tape too. And if I ever leave it somewhere, like if I'm on a trip and I leave it back, I'm like, I slept like shit last night. What the hell just happened? Oh yeah. I was probably breathing through my mouth. It's a lifelong battle.
Absolutely. I've gone down to the front desk and some of the hotels and just gotten, any kind of tape that they have. I've thought about using duct tape, but I've never had to. Just keep those lips closed. No, let's go to MRI imaging. Give us some of your favorite things as you observe those images in diagnosing and treatment planning.
Yeah. So the MRI side, this is what the questions I get if I'm out there speaking or showing, cases of why the MRI, is what it shows. The biggest question that I always get next is, okay, that's great. We saw it. That patient does have this disc displacement. how does it change your treatment plan? And so for me, what I put together, and I've done over 900 MRIs at my office over the last 3 years now at this point, and it's a huge part of my practice. But essentially, what I put together is a whole flow chart that pertains to ortho and restorative and airway, really. But basically, on if this on the MRI, do this, and if this on the MRI, do this, and kind of most importantly, what the if you see this is how bad is the disc displaced, and also how much inflammation is present. And that's the biggest thing that I think people start to look or ask why the MRI is important. They say, yeah, we know that patient clicks and pops already from our exam. Why do we need an MRI to confirm that? And my biggest answer to that is, well, the MRI is going to tell you just how bad it is in there, and also how stable is this joint going to be. Because we've all encountered those patients that click and pop and they've never had pain and their occlusion is pretty stable and everything's good out here. But then you also see the patient where they're like, hey, I've been clicking and popping, it's getting worse, and now I'm developing pain and all of that. And so the MRI really, again, lets you see that enemy under the surface and says, okay, you've got this pattern of disc displacement where that disc is not only forward but out, and now this medial pole of your condyle is not covered, and you're wearing away on that thing day and night as you eat, sleep, grind your teeth, whatever you're doing. You wouldn't have known which way the disc is displaced until you take the image. Yeah. You would just know that there was some displacement. And the other big thing, back to the inflammatory side, you don't know how inflamed that joint is until you see it on the MRI. And there are some people you're like, damn, we're fighting a forest fire here. There is no way this splint is going to be good for you, or the right, kind of matchup, or, you really we need to manage this way before we get into ortho. And for some patients, it says, wow, you really do need, a surgical procedure like what Dr. Mark Piper and Brian Shaw and everybody are doing, or pioneered and do. And it changes people's lives, not just from pain, but back to the ortho implication. If you get a disc back over the top of that condylar growth site, or if you get a fat pad graft into that joint on a young kid that's growing, that doesn't have a good joint, they regrow. They grow. And those class 2s start to they grow back, and it's awesome. And I track it all the time with the imaging I do, and it tells you, like, are we getting it or are we not? Because I hate guessing, and I think you get that from our conversation here. So.
Yeah, it's so funny as you're talking, like a lot of the dots are connecting for me. My first couple experiences at the Dawson Academy, and even going through Seminar 1, I can't tell you the number of instructors that use the words managing forces. Like, we can get all this perfect, but we got to manage forces. And at first I didn't know what that meant. And they're like, oh, you'll find out quickly, because those forces, a lot of times clinicians, whether they be restorative dentists, orthodontists, they don't think about the force management long term. And again, I'll go back to this. People are going to be living longer, than ever. And another thing that I've learned from great clinicians is everything we do is temporary. So I think you're spot on, Drew, with what you're saying. It's so cool.
No. Well, it's like I said, it tells the truth of what's going on, and it also helps us predict the future a little bit. But as you mentioned, it's nothing we do is forever. Right. And that's the other piece too, is like the MRI side of things tells me and the patient, like, you've got an issue, and this is not something that resolves by me fixing your bite out here. We're going to have to manage this the rest of your life to have a shot at stability. And ultimately, that disc displacement didn't just reattach itself. So you need to every night be protecting this thing with a splint as a retainer, or it sets realistic expectations is what I'm trying to say. And ultimately, the imaging side just really does show the truth of what's happening. And patients start to own their problems too at that point. It's not your issue. It's, I'm here to help you with your issue. And you need to be in charge of this too, kind of thing, to the patient. So.
Yeah, and let's take the clinician side of this. And so if you're listening, you're a young clinician, you know how this works. The more you know, the more you can help the patient, a true diagnosis. Now, I'm going to totally screw this thing up, and I don't know who said it, but I got to give it right. There are many treatment plans, but there's only one true diagnosis. Now, you're going to tell me what that means to you. Is that true in orthodontic diagnosis too,
Oh yeah, no, that's you can do many different ways of correcting in class 2, expanding. There's just every different type of tool. There's variations, whatever you need. But at the end of the day, it's what are you trying to achieve and why? And that's what I tell patients all the time is I don't want you to just know what I'm doing. I want you to know and understand why. And that's where the diagnosis part of the joints, the airway, I didn't even get into alveolar bone stuff, but man, the CBCT is helpful for knowing, is this patient going to have a lot of recession after I try and move these teeth and do all that? Or do they need some SFOT, like what George Mandelaris and my periodontist here in Albuquerque, we do these things all the time. But it's the image that showed the truth of where treatment needed to go. And the diagnosis under the surface led us to say, this is what we need to do.
Yeah.
And so, again, I feel like you can have many different plans to change the same thing, but you have to diagnose the case and you have to get that part right first. And sadly, I feel like in a lot of ortho right now, there's a pushback on imaging that there shouldn't be. And some people get thrown under the bus for taking CBCTs on patients, as part of their ortho, workup, because a lot of people just don't want to, they think it's over irradiating a patient. And in this day and age, the CBCT machines the one that I have and the ones that are coming out that you would buy if you're buying a new one, they have less radiation than, if you take a pano and a ceph as an orthodontic, on a 2D thing, my CBCT currently has less radiation out of it that I can see joints, airway, everything under the surface on than those two old images I used to take. And so, at what level do you feel comfortable going in blind on a case is kind of what I ask those patients, or not those patients, but doctors, where they're like, you shouldn't, why are you taking the CBCT? I'm going, well, I want to know everything about this patient. I want to know what's going to screw up my nice result. I want to know what I need to be encompassing with my treatment. And ultimately, I want to show the patient too. Yeah. So can you get that off your pano and lateral ceph? If you can, good for you. But I need this level to be able to operate at the standard of care I want to provide. And so, again, I on the CBCT level, I feel very passionate about it, especially that it helps so much on the diagnosis. The MRI is a huge part of the diagnosis and should be in the future of orthodontics. And it's going to change the way we operate. And it already is.
Yeah, I love this. I have like 4 more questions that I know we don't get that much time. I know you got to run. Gosh darn it. We should have planned a 2-hour show, but because this is a really important topic and there's so many layers to this, and we're going to have you back again and again and again. But any last thoughts you have on this, Drew, when it comes to the necessity of imaging in orthodontic diagnosis and treatment?
Yeah. So the biggest part of the future that I see is that this is going to lead the way to us being better professionals, better clinicians for our patients, and seeing our patients for what they truly are underneath the surface is going to be the future of the way we operate. One of the biggest, most important things I think we all need to embrace in dentistry, not just ortho, is how much we can be part of such the bigger picture for our patients. And that the imaging under the surface allows us to see those things that we can be a bigger part of. Yeah. And so on that note, we all need to be very confident in reading CBCTs. And if you're not, that's where, again, the OMR side of things is so important to the development of the future of dentistry. The radiologists they're gonna rule the world right now. I say this because everything that we are now looking at in 3 dimensions, the radiologists are interpreting this, they're guiding, for me, I'm so lucky that I have a former orthodontist as my radiologist that I work with, because he knows how these things play out together. And ultimately, if we take the image, we need to have it read, and we need to look for other pathologies, of course. But where I think the future of the radiology side in our profession is going to go is that radiologists are going to be helping us make good decisions on our treatment. Yeah. Again, pointing towards those airway issues, pointing towards joint issues, helping us know, like, hey, we need to be addressing these things. This is a concern if you're looking to do this type of treatment. Daniel Tamimi is somebody that I listen to a lot. I enjoy just looking at, the diagnosis part, but also making, extrapolations as to how does it affect your treatment? If this patient has this condition at the surface, what's it going to do to your treatment plan? And so ultimately, I feel like the radiology world is going to define the future of ortho. It's going to define the future of dentistry, because all those correlations we see at the surface have that under the surface. And if we start getting some papers out there and other things supporting what we're seeing in the radiology is supporting what we need to do orthodontically, dentistry wise, man, it's going to change the future of this sport. Yeah. And it already is. So I'm pumped, especially, I keep saying this, the imaging guides the treatment. The people who are behind the imaging side, which is the radiologist, are really who's going to be guiding the future of dentistry.
Yeah. Well, and I would argue your thought process and a lot of the great thinkers in dentistry are going to be guiding this process. And you talk about changing the sport. My friend, you are changing the sport and you're giving people a better life. So I'm so grateful to have you on. And I want people to, number one, if you guys are listening, if you have a study club and you have not had Drew speak to your study club, what are you thinking? Like, you got to have Drew speak to your study club. And then I also want people to follow you on social media. I'm terrible at it, but like, you've got a really great thing that you provide. Can you, if I'm listening or watching, how do I learn more about what you're up to? How do I follow you? What do I do?
Yeah, so on social media, it's Dr. Drew McDonald on my Instagram handle. I try and post as much clinically, like in regard to the up-to-date kind of newer technologies that I'm using on the ortho side. So you'll get to see a lot of MRI, CBCT, 3D superimposition technologies. Like basically, just I'm trying to push the future as much as I can. But I usually share that kind of on Instagram side. More importantly, things that I'm starting to get involved with. Back to Dr. Jim McKee himself, myself, Dr. Seth Atkins, who's in Texas, and then Dr. Kurt Ringhofer from Chicago. We're actually starting to do kind of some teaching on this together, and we're starting it with what's called the Chicago Study Club. So, if you're interested in joints, airway, all of this together, that's where you can kind of find us doing, twice a year seminars on these things. The other big thing I would say is that if you're interested in just learning about imaging in general and the joints in general, Dr. Mark Piper's Piper Education is amazing. You cannot go wrong going there. That's where he's taught me so much in terms of just the imaging, the MRI, the CBCT. What does it mean for treatment? And obviously what he does or used to do before he retired, which is how do we help these patients surgically, and how do you help them from all these other angles? Those two, Dr. Mark Piper is amazing. What we're doing together with Dr. Jim McKee is going to be a huge new thing. I'm so excited about it. So Chicago Study Club is the one that we're doing together. But again, Piper Education has such great courses that I'd highly, highly recommend.
Yeah. Well, how about this? I'll have you guys take it to Milwaukee too. I'll just volunteer you for that.
Just a short drive.
Hey, yeah. Jim was great. He was, like I said, he was always there for me at the beginning of my stages. So riding around with Jim, I learned a lot. I really learned a lot. So, Drew, this is awesome, buddy. I know you got to run, but I just can't thank you enough for being on. And we're going to have you back again and again and again. So stick around while we say goodbye to everybody else. But thank you guys for listening to the Best Practices Show. Hey, if you enjoyed today, like I know you did, just do us a favor. Hit the share button. Share this episode with your friends. And then keep sending us suggestions for things that you guys want to see. And if you really enjoyed today, do us a huge favor and give us a 5-star review, because what it helps us do is find other like-minded people like you. This is an amazing profession. It's a very noble profession. And I love getting the chance to make your practice and your life better. So keep showing up and keep hanging out with us. So next time, until we see you next time, or you hear from us next time, keep watching the Best Practices Show. You guys enjoy your day.